I'd like to present today a graft prep technique for quadriceps tendon, as well as our outcome data. We've been doing this since 2018, what we've come to term the Quadlock Technique. And it's been efficient, reliable, and reproducible for us. And of course, the quadriceps itself has many advantages. It's dense, it's thick, it's strong, with potentially less comorbidity and similar outcome to BTB. And it's been very customizable with both soft tissue and bone block ability, and in many situations it's been a Swiss Army knife for us. And I think it's been a challenge trying to understand how to connect a suspensory device to this tissue. And there was a great study in 2022 biomechanically looking at this, where they showed that potentially the best way is to connect it directly to the graft itself. And what we're going to show is how to both connect this into the graft with an intra-graft fixation, as well as have a suspensory locking technique around this. And so for this graft prep, we're going to measure and mark. We're going to place an angiocath as our shuttle device, and we're going to do a double locking technique around this and then place our suspensory through this for the final construct. And as you can see, it's a relatively small footprint on the back table. We have our two Alice clamps, two 16-gauge angiocaths, some hemostats, and our graft table. And I'd just like to note that if you're going to be using quad allograft, it's a lot easier to make your cuts while it's still relatively frozen. And then as you begin to lift this, it'll become much more pliable, and this will save you some time and headache. But we're going to try and get about a 7-centimeter graft. Here I've placed two marks at one end, one on the other, just for purposes of this presentation. And our lines are going to be placed at 15 and 20 millimeters. And so as we set this graft, I'm going to show you some different materials that you can use. Now, there are commercially available loop sutures that have a tape swedged to the end on them already. Now, you can make this construct yourself if you like. You can just take a tape and a loop suture. And I'll demonstrate this for the technique, but what you can do is just put a luggage tag through the swedge of a tape suture and make your own looped suture tape construct if you'd like. Now, this double locking technique, I don't think you really have to use that because it's so robust. But if you're more comfortable placing a tape over top of the graft and using that to help to improve some of your fixation, that's how I'm going to demonstrate here, but I really don't think you have to with this technique. And so I'm going to put two Alice clamps on this, and we're going to put this on our graft table. And if you are going to use the loop suture tape technique, we're going to first place our needle at the 20 millimeter mark. And I'm going to put my 16-gauge angiocath in now. And I just do it on one side. If you do it on both, it tends to get in your way a little bit. And so I'm just going to do it one at a time. And we're going to first put our needle through at the 20 millimeter mark and push this through. Now, of course, if you're just going to use a typical looped suture, then you're going to start your loop at this point and start the whip as you normally would. But here we're going to first pop through with our tape suture, and then this is going to lay over top of the graft. And you can see we have a lot of excess. So you can put your hemostat on this just to make it easier for your assistant so they can hold both in the same hand at once. And then we're going to cut off the excess suture at the end of this. The strategy behind incorporating the tape is really due to the underlying morphology of the quadriceps fibers, as they tend to run relatively parallel. And this was done in an effort to improve fixation, decrease creep. However, again, with this technique, I think it's really much less of a concern. And so we're going to start out, we're going to get 2 throws before the angiocath, and you're going to want to leave some space in between these as we're going to come back around to do our locking suture. But we'll place this and tension it, and the next pass we're going to go right up and tight against the angiocath, but not through it. And you can move the angiocath back and forth a bit just to verify that you haven't captured this and that we've left room for our future suspensory placement. But this, again, we're going to place right up against the angiocath. We're going to hop across the other side. The angiocath is really a safety feature in this technique. A great article in 2015 with Drs. Kroll and Gilmer. And this is how I started out by doing intra-graft fixation, is you can make a split at the end of the tendon with a 10 blade and then utilize the natural split on the proximal aspect. So you can place either a closed loop or other suspensory construct through this and then whip around it. However, there is some risk that you're going to capture suspensory, and in fact, this happened to me in 2 cases, which is, of course, very devastating when you go to reduce your suspensory and find that it won't do it because you've captured it. And so this is going to keep you out of a lot of trouble by doing it. But I've gone to the other side of the angiocath here, And again, we've left space between angiocath and the throat so that when I come back around, we can lock this. As we play this, I'm going to come back around now, and this is going to be our first locking suture. And just as you typically would, I'm going to go right behind that prior suture placement on this side of the angiocath, put this through and lock it, and that's going to be our first locking suture on this side. And then I'm going to jump across to the other side again, on the other side of the angiocath, and we're going to do the same thing and just do a simple locking suture on the other side as well, just right behind that prior placed pass. We're going to put this through and tension it. And once you put that, you're done. And you can feel very confident that when you put your suspensory through this, you're going to have a length stable position, and it's going to be able to tolerate a high degree of tension. And it's relatively high up in the graft. And this is due to the fact that we're going to have our suspensory tension much closer to the knee, similar to aperture fixation in that regard. And so once I put this and tension it, then it's just a matter of finishing out our throws to get to the end, and we can test our angiocath to make sure that we're still having free movement in that region. And typically we'll probably get about 3 or 4 more passes as we get to the end. Because the fibers run relatively parallel, you'll see that as you get closer to the Alice clamp at the end, it's going to want to try to pull out, which is fine. And in fact, I do put a relatively high amount of force through these last passes just to see if it will, because if it's going to pull out now, this is a good time to see it do that, because then we can certainly incorporate that. That's not going to be a problem. But once we get to the end of the tissue, then I'm going to do one more locking suture just to set the whole construct, and in similar fashion just go right behind that last pass as you typically would. You'll see that there's going to be a lot of material at the end of the quad, and there's going to be some dog ears, but this is a good opportunity to use the Keith needle, and we're going to go across this and capture all of that tissue and then tie this in, because it's going to do a great job of bulletizing this and save you some time from having to trim excess tissue out. So I'm going to place that across, and then we're going to tie our knot stack at the end. And that knot stack I'm going to bury as well, so that way it's not sticking out at the end of the graft. And so I'm just going to put this through and bury it, and the tissue tends to be really thick, and so pretty commonly I'll have to use a needle driver or other clamp to help get through, but once that's passed, then I can cut off the excess tape that we used in this demonstration. And now this end of the quadriceps is done, and we can move on to the other side. So now I'm going to flip this around and secure our other side to the graft station. And on this side, I am going to demonstrate the commercially available suture material that has the tape already swedged on. And you'll see it's cut to length, so it fits quite nicely across the end of the quadriceps tendon. One of the benefits of this is that the suture ends are actually a little bit longer, which can become important in patients who have large thighs or larger body habitus, because you do need to find the suture ends outside the thigh, particularly on the femoral side. And so we're going to go ahead and do this similar technique, and this is our finished product. You'll see that nicely maintains our ribbon-like morphology, which, as we understand more about the ACL, may have much less of a bundle as it is a ribbon-like structure, which is another benefit for the quadriceps tendon and doing this technique. You'll see this is incredibly stable to testing, and as mentioned previously, once you pass your suspensory device into the graft, you're going to have a very length stable construct that's going to be similar to aperture fixation, where the tension is going to be much closer to the knee itself at the entrance of the tunnel, with your whip stitches going to the nose, so that you can help guide it in but also act as backup fixation. And so you can pass those whip stitch ends into your button, whether you use a Keith needle or other device to put that through. And I do use a knot pusher to tie these on the femoral side at the end of the case, where final tightening is done with the suspensory so that the tension is felt through the suspension at that length stable position. And here's the final product ready to pass. We presented this 95 cases, minimum 2-year follow-up primary ACL with 1% failure rate. Our average graft size was about a 9. It does take some time to regain the extensor in our cohort, about 6.5 weeks, but with relatively low chronic anterior knee pain. And so it's been a pleasure to present this technique, which we believe is an efficient, reliable, and reproducible way to consider doing your quadriceps ACL reconstruction.